Welcome, Jean-Louis. Good morning. Not only transthoracic, but more large Echo Doppler technique, how to use it in practice. You remember that yesterday I told you that there are clearly two different levels regarding critical care echocardiography. A basic level and an advanced level. I think that nobody can see anything on this slide, but just to well differentiate the two levels of critical care echocardiography and two levels, two different approach and two different applications. The first level is the basic critical care echocardiography. In this situation, you can use echocardiography as an help, only an help to hemodynamic diagnosis. Most of the time it's by using a transthoracic route, and it's more a classical hemodynamic approach. You have to have competencies, of course, in critical care medicine. You have to know the different types of shock, and you have to know the basics of physiology regarding the heart function to well interpret what you see on the screen of the machine. And so, for instance, at 2 hours in the morning, you take a patient in charge for clinical signs of shock, or because you have a combined continuous monitoring of cardiac output, you see a significant decrease in cardiac output, and you want to know why. And if you want to know why, you can do the right diagnosis using a transthoracic echo, very focused on simple parameters. And you want to know if there is severe hypovolemia, if there is left ventricular failure, if there is right ventricular failure, and of course if there is fluids into the pericardium inducing cardiac tamponade. And after that, of course, you can adapt the treatment and you can give the right treatment to the patient. So look at very simple parameters, very focused. And Benjamin's team in New York called this approach early goal-directed echo. And you can be very confident by using this approach, because this was clearly demonstrated by Philippe Vignon, who is working in Limoges in France. And he demonstrated by applying 3 hours didactics for intensivists associated with 5 hours of hands-on. The intensivists were confident regarding these different kind of patterns to look for hypovolemia, to look for LV dysfunction, to look for right ventricular dilatation. So very focused training, 3 hours didactics, 5 hours hands-on session. Of course, you can do better, you can do more. Look at an example. Patient in shock. You put the probe in the subxiphoid situation, place, and you can visualize the inferior vena cava. And look at here the very small inferior vena cava associated with the very good contractility of the left ventricle with a systolic exclusion of the left ventricle. You know that in this situation, your patient requires fluid infusion. And indeed, this patient received fluid infusion, permitting to correct the systolic arterial pressure and to decrease the heart rate. Another situation, look at this young woman. She was admitted into the emergency room because of very severe sepsis, and she was severely hypotensive, and she received fluids and fluids and fluids into the emergency department. And along she received fluid, she exhibited more and more pain into the liver. And when she was admitted in our unit, we performed a very quick echocardiography. And look at now the IVC. The IVC was very congestive because this patient had a right ventricular dysfunction related to the septic process. And so in this situation, it's very easy to know that the right treatment is probably to give the butamine, and indeed few hours later the clinical situation was much better. And look at now the IVC diameter. The IVC diameter was significantly decreased, only reflecting the improvement in right ventricular function. Of course, you can do many and many diagnoses very, very simply. You can observe very easily acute cor pulmonale, associating right ventricular dilatation and paradoxical septal motion. As you know that in case of shock, if you see this kind of pattern, maybe you have to think about massive pulmonary embolism. And you can also see this kind of disease. It's not very interesting. It's more a cardiological approach. But of course, in our unit, sometimes we have to take in charge cardiac tamponade. And it's very easy to know what to do in this patient. The second level induces a second very different approach, advanced critical care echo. Now it's not echo for helping you in the hemodynamic diagnosis, but you can use echo as the main monitoring device, really. And this is what we call a functional hemodynamic monitoring, a very integrated approach. And you have to be confident, of course, in transthoracic echo, but also in transesophageal echo. And you have to know many, many basics regarding heart-lung interactions, regarding respiratory mechanics, and regarding physiology and pathophysiology, of course, of the right ventricle and of the left ventricle. You can decide to perform an echo by a transthoracic or transesophageal route because of a clinical suspicion. My blood pressure is low, my lactate level remains elevated, my base deficit remains elevated, or the urinary output of my patient is low, I don't understand why. Or you can decide to perform an echo for a systematic hemodynamic evaluation in the most severe patient in septic shock or in acute respiratory distress syndrome. You can decide to do an echo at D1, D2, D3, whatever the clinical situation. And you can also decide to perform an echo to check for the change related to the treatment. You want to know what happened when you increase the PEEP. You want to know what happened after prone position or after norepinephrine or dobutamine infusion. And so you can do the right hemodynamic evaluation. But you know that there are many parameters that were described using this technique, and you have to well know the limitation and the pitfalls of these different parameters. And you have to be able to interpret the examination according to the clinical situation, of course. And it's very important, I think, that after enough experience, we spoke about that yesterday, you have to be able to give a qualitative evaluation, not to do measurement because of the variability of measurement or because of the risk of errors. You have many informations only by describing what you see on the screen of the machine, but it requires some experience in the device. And finally, you can take the right decision and the right treatment. And I think it's a key point, and Jean-Louis remind this point. Avoid repeating the mistakes made with the pulmonary artery catheter. You have a device, you do an hemodynamic evaluation, and you have in your mind the protocol and the change in treatment according to the evaluation. And so you can re-evaluate the patient after changing the treatment. Yesterday, some of my friends in this room told me that it was a pity not to speak about cardiac output measurement using echo. So this is for my friends. Of course, echo, it's very valuable for measuring, for calculating cardiac output. But when I want to do, I'm not sure it's very interesting, but when I want to do, I much prefer to monitor the stroke volume rather than the cardiac output. Because as Riel said, there are many situations where the cardiac output can be maintained or even elevated because of tachycardia for any reasons, whereas the LV stroke volume is very low. And what I want to know is what happened regarding the heart function. So how is the left ventricular stroke volume to adapt the treatment? And so you know that, of course, and we discussed this point yesterday, you can measure the stroke distance, and so you can calculate the left ventricular stroke volume using the Doppler technique. It's very simple and very accurate. And just to see you, Our students, after 1 month of training, 3 months of training, 6 months of training, and you have the difference of measurements between the expert and the student regarding the left ventricular stroke volume. And you can see that after 3 months, but better after 6 months, most of students were able to accurately predict, calculate the left ventricular stroke volume when compared to the expert, with an error of less than 20%. So, good technique, easy to be trained. But it's more interesting to see how the heart is moving and what happened regarding some vessel as the superior vena cava. And as you know, we described the superior vena collapsibility index to predict the response to fluids. It's a good parameter. Look at this example. It's a very nice example because the expiratory time is very long. And you can see the refilling of the superior vena cava during expiration and the collapse of the vessel during insufflation and the refilling of the vessel during expiration. When you see this kind of pattern, whatever the clinical situation, my feeling is that you need to give fluids to the patients because there is a significant hypovolemia. With enough experience, of course, as I said, you can maybe not measure the SVC collapsibility index, but only evaluate the respiratory variations of the vessel. And so we publish this, and you can accurately have an idea of how varies the superior vena cava without any measurements. But what is very interesting is that you can, for instance, put the probe into the esophagus and keep in place the probe when you change the treatment, and for instance, as demonstrated here, when you apply a PEEP. And look at this patient. This patient was under mechanical ventilation for acute lung injury and severe sepsis. And at baseline, when we start the examination, the patient was in ZIP condition. You have the pulse pressure variation, 9%. You have the LV stroke index, 30 milliliters per square meter. And look at the echo. You have the RV ejection flow. You can see slight decrease in the RV ejection flow during each insufflation, and you can observe the SVC with moderate respiratory variations of the vessel during each insufflation. But because this patient was severely hypoxemic, we decided to increase the PEEP, not so much in our unit, 5 centimeters of water. It's the mean PEEP that we apply. And you can see the pulse pressure variation was now 11%. And what happened regarding the echocardiography, look at now the huge decrease in the RV ejection flow during each insufflation. And this was due to a total collapse of the superior vena cava during each insufflation. And look at now the left ventricular stroke index. So what can you do in this situation? Of course, not removing the PEEP, because this patient needs PEEP. So we infused fluid, of course, 500 milliliters. You can now the pulse pressure variation, no pulse pressure variations. And look at now the right ventricular ejection flow and the respiratory variation of the superior vena cava. You can observe the disappearance of the collapse, and the left ventricular stroke index was significantly increased. So this is a good demonstration how to check the efficacy by keeping the probe into the esophagus. Another thing very interesting at the bedside using echo is to do the difference, and sometimes it's not so easy because a cardiogenic shock and a septic shock with severely depressed contractility of the left ventricle. And you know it's very quite different using echo. Cardiogenic shock is associated, of course, with a depressed contractility of the left ventricle, but most of the time in chronic situations with the dilatation of the left ventricle. And you can observe depressed contractility and dilatation of the left ventricle. And for some of you who know very well the echo, you can see a thrombus into the left ventricular cavity. And this is associated with very high left ventricular filling pressure. This is the definition of the cardiogenic shock. And look at the mitral profile. You can see what we call a restrictive pattern with a very a very high E wave velocity and a very low A wave velocity. This is a very specific, typical pattern of very high left ventricular filling pressure. It's very different in septic shock with depressed left ventricular contractility. Look at this patient. The left ventricle was non-dilated, but look at also the severe decrease in contractility of the left ventricle. But this was associated at that time with normal or low left ventricular filling pressure. And look at now the E on A ratio. The E on A ratio was normal for a patient under mechanical ventilation. So you can do the difference very easily using echo between a typical cardiogenic shock pattern or the typical septic shock pattern associated with LV depressed contractility. And you know that, as I said to you, you can check the efficacy of the treatment. And look at this paper we published in Critical Care Medicine in septic shock patients, more than 60 patients, and you can observe the LV ejection fraction before dobutamine, for instance, and after a few hours of infusing dobutamine. And you can check the efficacy of increasing or of infusing dobutamine. And look at an example here, severe depressed left ventricular contractility, and after a few hours of dobutamine infusion. And of course, this is the same if you want to decide to give epinephrine rather than dobutamine. But I want to say you a very important thing. When you assess the contractility of the left ventricle, especially in septic shock, most of the time you calculate the LV ejection fraction. And as you know, the LV ejection fraction depends on the intrinsic contractility of the left ventricle, but also the left ventricular preload, afterload, sorry. And maybe you know this nice paper from Robotham, and you can see here the systolic elastance of the left ventricle, which reflects the intrinsic contractility, the intrinsic function of the left ventricle. You can see in red here the normal values. And so in a patient in septic shock with a depressed systolic left ventricular contractility, you can see that if the afterload is very low, you can have a normal ejection fraction. But if you restore the afterload by infusing norepinephrine, you may unmask the left ventricular systolic dysfunction, and so at that time you will observe the decrease in the LV ejection fraction. And maybe you know there are many and many data in animals and in humans that the left ventricular systolic dysfunction is constant in septic shock. Most of the time you can't see the LV systolic dysfunction because the afterload is very low. But keep in mind that if you restore the afterload, you may unmask the LV systolic dysfunction. And we observe this situation in many patients, but look at an example in this patient, hospitalized for a septic shock from an urinary origin. And look at baseline before infusing norepinephrine. You can see an hyperkinetic state. Look at how is working well the left ventricle, and what happened few hours later after infusing the norepinephrine and restoring a normal afterloading. Look at now the situation. The situation is very different with a severely depressed left ventricular contractility. And so maybe in this situation, according, of course, to the clinical scenario and according to the blood pressure, to the base deficit, to the lactate level, to the urinary output, you may decide to infuse the dobutamine. So I finished in 1 minute, in 2 minutes. I am on time. 1 minute? We may propose this kind of protocol, maybe in septic shock patient. At admission, you have to sedate, to intubate the patient, to put the catheters, to give volumes, and most of the time to start norepinephrine. After 2 hours, the first step is to perform an echocardiography by a transthoracic or the transesophageal route to check for the efficacy of the early resuscitation. And you have to see how is the fluid responsiveness of the patient, maybe by using the SVC collapsibility index, but you have many parameters which was published using transesophageal or transthoracic echo. And if you have fluid responsiveness, probably you have to continue volume expansion if the shock is not resolved. After optimize the volume expansion, you have some guidelines, some goals that you want to reach regarding the mean arterial pressure, regarding the base deficit, regarding the lactate level. And so if the goals are not reached, you have to increase the norepinephrine rate. And after 6 to 12 hours, there are two different situations. First situation, you reached the goals, and so you are happy, and you can continue to monitor your patients. The second situation, you do not reach the goals, and so maybe you have to do again a new echocardiography now to check how is the left ventricular ejection fraction. And if the left ventricular ejection fraction is low, probably you have to give the butamine to reach the goals. But if the left ventricular ejection fraction is normal and if the right ventricular function is normal, there is a problem for your patients, maybe a problem regarding the microcirculation. And in our unit, in this situation, after 12 hours, we discuss some other interventions, some other drugs as continuous veno-venous hemofiltration or activated C protein. Thank you for your attention.